This is the special test for the knee video. So first, we're going to do valgus at 0 and 30, testing for the MCL. So you're going to apply valgus stress at 0 degrees, so when you're at extension. So you're going to hold here and press and make a medial force here at the knee. And then you're assessing for excessive opening on the medial side of the knee. And then you're going to go into 30 degrees of flexion and do the same thing. So press here, apply force, assessing for excessive medial opening. So that's for the MCL. And then you can also do a varus 0 and 30, and that's for the LCL. So you would come in side here, and you would apply a varus force, which would be pushing lateral. So I'm going to use this arm and press, well, I would do 0 first. So press here, and then you would do 30, do it again. And you would be assessing the lateral opening, excessive lateral opening on that side of the knee for LCL. So yeah, MCL and then LCL. Now we have Lachman's, which is the first ACL test. So for that one, we will be doing about, you can do like 30 to 40 degrees of flexion. So I'm going to put my knee under my thigh under the patient's knee. I'm going to stabilize here, and I'm going to use this hand to apply a anterior force and assess for excessive movement. So I'm stabilizing here and pulling anterior with this hand, and that is assessing for ACL. So if that was more like unstable, then that would be a positive. And if it's more anterior displaced, then this one, it would be a positive. So that is Lachman's. And then we will do axial pivot shift for the ACL. So we would bring the patient up into 90 degrees, and then I would be applying a, make sure I'm doing this right. So I'm going to be doing an internal rotation of the lower leg here with this arm. And then I would add just a little bit of a valgus torque and then bring the patient into extension, and I would be assessing for a thud. So I'll do it again. So we'll start up in 90 degrees, internal rotation of the lower leg or the tibia, and then add a little bit of a valgus torque and go down. And then a palpable thud or a click would be a positive for ACL. And then anterior drawer test, we start here, and I would be sitting here. So maybe we'll come over here. No, you're fine. So I would sit on the patient's foot here and put my thumbs on the joint line here, and I grab the tibia, and I'm taking my hands and pulling anteriorly to apply an anterior force. And if this translated more anterior versus the normal side, then that would be a positive. Yeah, so that's all the ACLs that you wanted us to do. And then moving on to PCL. So the first one would be the posterior sag test. So I would bring the patient up into 90 degrees of knee flexion, and I would be assessing for the tibial condyles going posterior to the femoral condyles. And if they did, that would be like an observation, then that would be a positive sag test for the PCL. And then along with the posterior sag test, you can also do the posterior drawer for the PCL. So you would bring the patient down, and they would be in that flexion, and I would go ahead and sit on the patient again on their foot, and it would be similar to the anterior drawer, except you're pushing posterior. So I would grab the tibia, thumbs on top of the tibial plateaus here, and then I would press posteriorly. And if this translated more posterior than the normal, then that would be positive for a PCL tear. And we know some grades for that. Less than 5 is grade 1, 6 to 10 millimeters is grade 2, and then grade 3 is greater than 10. So yeah, that was PCL. And then we'll do the meniscal tears next. So McMurray's would be your first one. And in McMurray's, we start in 90 degrees of flexion. And then if we're testing the medial meniscus, I will want to have this hand here feeling for the medial side of the knee. And then I'm going to apply an external rotation force at the tibia and then slowly extend the knee. And if I felt a palpable like thud, then that would be a positive. So I'll do it again. So we start at 90, we apply an external rotation force, and then slowly extend. And that would be a positive if I felt a thud or a click. And then I can also do a lateral meniscus test for the McMurray. So I would do an internal rotation of the tibia, feeling for the lateral condyle and into the lateral meniscus. And then I would slowly extend. So I'd probably go here and then down. And if I felt a palpable thud, that would be a positive for the McMurray's test. I believe that is all for those. So now we will do, we need to do Apley's.
Apley too.
Yeah. Apley, so that would be prone, so I'll have you get on your belly. So for the Apley, you comfortable?
Yes.
Okay. So the first one, we would do a distraction. So so I put a force on the patient's thigh so that way it's stabilized. And then I'm going to grab the patient's leg here and I'm going to pull up into a distraction force. And then I'm going to do some internal and external rotation of the tibia. I would be assessing symptoms, ask the patient how they felt. Any pain with that?
Nope.
So then I would back off and I would do a compression. So I would press down and then I would do more internal and external rotation and assessing symptoms. And if the patient felt more pain with the compression than the distraction, then that would be a positive meniscal tear or meniscal pathology. And then, is that all for that he wanted us for that?
Mm-hmm.
Yeah. Okay. So then I'll have you lay on your back and we'll do patellar dislocation. So for this one, this would be one of the ones would be the patellar apprehension test. So I would bring, can you scoot over just a little bit? Bring the patient off in passive 30 degrees and I have him resting on my leg here. And I'm going to tell the patient, okay, so I'm going to provide a little force to your tibia or to your patella here. So I pull this way. And if the patient either A says, no, I don't want to do that, or if they lock out into extension, then that would be a positive for patellar dislocation. So I would either do a lateral force and see how they tolerated, or just seeing how they acted. If they were apprehensive or lock out their knee, then that's a positive. And then next we have the Clark's test, which is the a provocation test for why can't I use words?
PFS.
Yeah, patella.
PFP.
Patellofemoral pain syndrome. There we go. So for the Clark's test, I will apply a downward force on the patella. And then, all right, now can you contract your quad? Thank you. And then relax. So what I did there, I applied a downward force on the patella and then had the patient contract their quad. And if that was positive, then it would be because the patient didn't want to contract their quad because of pain, or if there was crepitus, that would also be a positive. Yeah. And then, let's see, what do we got next? Blottement. Yes. So this would be for like an effusion assessment for blottement. So I'm applying a compressive force superior to the patella and then inferior to the patella, and then I would cup them together and then bring them in a little bit, and then I would do a tapping on the patella. So if I suspected that there was effusion, then the patella would feel like it's floating or kind of tapping back at me, and you're trying, by pressing your hands in, you're just trying to assess if there is fluid. And if there is fluid, then the patella is going to float because there's fluid underneath of it. Yeah, so that's just assessing for swelling and effusion. And then the last one is the Noble compression. So this is for IT band. So I'm going to put the patient, flex them to 90, and I'm going to apply a force, a lateral force at the distal end of the IT band. And I'm applying this force and then going through flexion and extension. And a positive of this would be if the patient reports pain while performing this test. So you just kind of slowly extending the leg. And one thing to note on this is at 30 degrees, the IT band translates on top of the epicondyle, like anterior to it. So it would be painful when you were getting into that 30 degrees. And did I miss anything?
That's it.
Okay, that's it. Thanks.